Good afternoon, everyone, and welcome to the EPIC Conference 2023. And this is the session on cognitive health and dementia. My name is Frank Knoefel. I'm a physician in care of the elderly. I've been practicing for just over 30 years, and I'm a scientist with AgeWell, and I have an appointment at the Faculty of Medicine at the University of Ottawa, Systems and Computer Engineering at Carleton University. And that's because of my interest in technology and aging. I'm part of the SAM3 group here in Ottawa. And yeah, so really excited about this session today. So the challenge area that we're talking about today, of course, is cognition and or dementia and cognitive health. And for me as a clinician, I always think about the big domains that are associated with aging as being sort of the medical complexity side, where medical challenges accumulate. But then mobility being one of the giants and cognition being the other giant. And of course, how the brain works and how we convert chemicals and electrical current into thought and speech, of course, is a very exciting domain to be in. And so today we're going to have a great time. We have three great presentations today. And yeah, so the speakers today are Natasha Galin, Barbara Delacourt, and Guillaume Spalla. And we're also excited to have Genevieve Zelatny as our commentator. So before I begin, there's a couple of housekeeping items. So as you know, the challenge area presentations will be taking place on Zoom from 1 to 2:30 Eastern time every day this week. With the final session on Friday, with the closing on June 2nd. I encourage you to check out the AgeWell EPIC Conference webpage for additional details and registration information. So today's session will be comprised of 3 oral presentations, followed by a 5-minute Q&A after each presenter. Then there'll be an overall follow-up comment. And then there'll be an exchange and a larger discourse subsequently with concluding general Q&A. So we do encourage all attendees to use the Q&A box, please, for your questions. You can leave a comment on a question. You can upvote questions that others have submitted, but please use the Q&A box for that. This session is being recorded and will be available for playback, with links to the playback being posted on the EPIC Conference webpage and the AgeWell YouTube channel. So I think after all that, we're ready to begin with the presentations. So it's my pleasure to introduce our first speaker, Natasha Galin. Natasha is an assistant professor in clinical psychology at the University of Regina. As the director of Aging, Residents, and Caregivers Research Unit at URegina, she is passionate about using research in a way that meaningfully improves the quality of life of Canada's aging population. Her current research interests include the use of implementation science methodologies to improve the lived experience of long-term care residents and their caregivers, the role of psychosocial factors in influencing health outcomes among middle-aged and older adults, and cognitive, behavioral, and mindfulness-based psychological interventions for adults living with chronic diseases or acute illnesses. So please, again, put your questions in the Q&A. Natasha, welcome, and please begin your presentation.
Thank you so much, Frank. I am going to start by sharing my slides. So thanks for that introduction. I'm Dr. Natasha Gallant. I am going to talk to you about time perceptions and dementia today. Now, this is sort of an area of research that was not my primary program of research, but became very interesting to me after, I guess, just in conversation with people, honestly, just watching also The Father, which is a movie with Anthony Hopkins playing the role of someone who has dementia. And I think just seeing the lived experience of living with dementia and how time might play a role in that. So as most of you probably know, dementia is a set of symptoms caused by disorder of the brain that includes memory loss, difficulties with problem solving, thinking and language, and changes in mood and behavior. But I think the bigger question is, what is time perception? What do I mean when I say time perception? So the definition I'm using here is this ability to estimate periods of time lapsed, so the passage of time or the duration of time. And in the experimental literature, as I started to become familiar with it, there are two paradigms, two ways that people can, or that experimenters can test time perception. One is prospective timing tasks. So really participants are told in advance, we're going to do this task, this experiment, and at the end, you're going to have to estimate a time interval. So you're aware that time will be measured. And then there's retrospective timing tasks where participants are not told in advance that they'll need to estimate a time interval. So let's say you do an interview with an assessor, and at the very end, as part of this experiment, you're asked, how long do you think the interview took? And you wouldn't have had any access to clocks or any time. And it's to see how time passes for both those, for those with dementia. And what I'll be looking at is also comparing those with dementia to those without dementia. So like I mentioned, memory loss is one of the most key components of dementia in terms of its symptoms. And it's closely intertwined with our perception of time. So there's emerging evidence that people living with dementia have memory loss along with distortions in time perception. Time perception, however, has not been investigated very much. And it might be overlooked as a target for assessment and intervention. We often focus on improving memory or testing memory to see if someone has dementia or if it's progressed. But what about time perceptions? Is that a new area we could be looking at? So what we did is a scoping review. So scoping review really is to map out the literature, what's happening in this broader field of research. And that's why there's sort of a map here with a few pins in the map. And so what we did is we searched for terms related to dementia, terms related to time perception. We looked in lots of different scientific databases, so CINAHL, Embase, Medline, PsycInfo, ScienceDirect, and Web of Science. We included studies conducted in any country, published in any year, but we did only focus, and this is probably a limitation, on quantitative study designs. So if there was any qualitative study asking those with and without dementia about the passage of time, about how they experience time, we didn't include that. And I think that would also offer something to the literature in the future. What we did include, though, are studies that included at least one group of individuals living with dementia and at least one comparator group. So whether it was two different types of dementia, so there's only one study I'll talk about later that looked at those living with probable Alzheimer's disease versus probable dementia with Lewy bodies, or more commonly, it was those living with dementia compared to either people who were healthy, age, education, and gender matched controls, or who were or who had mild cognitive impairment or subjective cognitive impairment. And so as long as they were looking at some sort of time perception outcome, they were included in the study. So there's three outcomes that I'll talk about today. The first is average time estimation. So In studies where, for example, maybe there's a red button on a screen that's there for 15 seconds, after that 15 seconds, everyone's asked how long that lasted. And then what we find is those who have dementia with Lewy bodies are actually estimating longer periods of time than those with Alzheimer's disease. So they might say it's 20 seconds, 25 seconds, just as an example, compared to those with Alzheimer's disease. And that's the only study that compared two different types of dementia. The most common group that was looked at was those with Alzheimer's disease. So when we compared those with Alzheimer's disease to healthy age and education matched controls, there was 3 studies that did that, and they found that Alzheimer's disease population, the group, estimated longer time intervals than those who did not have dementia. There's one study who didn't find this when they compared it to healthy age and education matched controls. So still a little mixed results. And then the last one was comparing those with Alzheimer's disease to mild cognitive impairment and subjective cognitive impairment, and there were no differences here. And this is sort of a theme that comes up, is that when we're comparing those with Alzheimer's disease and either mild or subjective cognitive impairment, there doesn't seem to be any differences. But when we compare it to healthy age and education matched controls, there's more often some differences there. So next we have absolute error values. So what this is looking at is, we're looking at that correct value. So the amount of time that has passed, for example, and the estimate, and we're looking at how many absolute errors are occurring. So absolute meaning it doesn't matter if people are over or underestimating, we're still going to count it as differences here. And what we found was that those with Alzheimer's disease had greater numbers of absolute error values compared to healthy age and education matched controls. And in one study, age, gender, and education matched controls. We found there was one study again that didn't find any differences among those who had Alzheimer's with Alzheimer's disease, dementia with Lewy bodies, or healthy age and education matched controls. And once again, Alzheimer's disease compared to mild or subjective cognitive impairment, there were no differences there. The last one here is coefficient of variability, which is how variable the estimates are. So when we look for healthy age and education matched controls, what we see typically is, if it's a 15-second interval, their guesses might be 13, 17, maybe 18. It's less variable than Alzheimer's disease, which might range, for example, from 5 seconds to 30 seconds. So what we found in one study, actually in 3 studies, was that Alzheimer's disease, there was more variability in their answers compared to healthy age and education matched controls. And then when comparing Alzheimer's disease to dementia, there was, with Lewy bodies, there was also more variability. So what does this all mean? This is very preliminary. We're looking at time perceptions in dementia. It's not an overly looked area. There was only 10 studies in our scoping review. But maybe if we pursued this area of interest, we could better understand dementia by addressing these time-based altered perceptions. Maybe we could add some of this knowledge to psychological treatments that include a time-based component. So reality therapy, reminiscence therapy is often used with dementia populations. Could we integrate time-based understandings or even mindfulness, which is focused on remaining in the present moment? Self-report questionnaires maybe could also be used to assess for altered perceptions of time in those with dementia. And I think there's a societal piece here about shedding light on the ways in which daily life could be temporally structured, or how time could be structured to provide those living with dementia with improved quality of life. We talk often about age-friendly cities, communities, and I think we often are focused on space, but what about time? Do appointments need to be kind of scheduled in a rigid manner or scheduled super quickly? Can we shift the way that we think about dementia and time? And this is a conference on aging and technology, so I wanted to think about some of the potential implications for technology as well. So I think there's lots and lots of tools, technologies that we're developing to identify and monitor dementia and related behaviors like wandering. And I think maybe we could also integrate a better understanding of time perception into the development of these technologies. Now, I'm not the one who usually does the development of the technologies, but some of the folks out here might be doing this. And some of the technologies that we already have, maybe they could be modified to better fit those with dementia by incorporating this understanding of time perceptions. And finally, maybe we could develop interventions that improve time perceptions among people living with dementia in a similar way that we're looking to improve memory whenever possible. So that concludes my chat or my talk. And if you have any questions, I think we have 5 minutes. I'll pass it back to Frank.
Thank you, Natasha. And what do we have? I don't see anything in the people are shy to ask questions. So maybe I'll start. So, I mean, this is certainly something I see in clinic often. I mean, the whole sense of time, we ask questions about orientation to time, of course, as part of the questionnaire, but there's, like you say, there's beyond that, there's the sense of time and the passage of time. And, you know, and a lot of families do spend a lot of time trying to reorient the person they're caring for to, you know, when is the next meal, or, you know, when am I allowed to have my next cigarette, or whatever it is. There's that complicated sense of time. So if we were going to incorporate, let's say, some kind of other testing more about the passage of time in the literature that you saw, was there like a sort of a model of a 2-minute test that you think we could add to our cognitive testing that we're doing already in clinic that you would recommend, or is this part of what you're looking
right
at?
now? There's nothing out there. The experimental studies were mostly looking at, they showed people like an interval of time, or whether it was by sound or by visual stimulus, and then people estimated length of time. There's like no norms or anything, but maybe we could develop norms around how long someone should estimate a 15-second interval if they do or don't have dementia. And maybe that would be something that could be incorporated. That's kind of where my thinking goes, because I'm in psychology, so I think about that.
Okay, we have one question in the Q&A, so I'll just read it. When you state there are time perception differences in Alzheimer's disease compared to age-matched controls, what is the specific time difference? For instance, 3 minutes versus 2 minutes and 30 seconds is a 30-second difference. And then related, are time perception differences between dementia and healthy controls stable? So is it always a 30-second difference
Right.
for a period of 2 minutes, or does it
So
change?
all of the experimental studies, like case control studies that I looked at, the greatest interval that was measured was 60 seconds, which is not a lot of time. But there were some studies that did either like an assessment or an interview or some other task, and then asked how long people thought that event took. And there was also some differences there, but there was only a couple of studies looking at that. So I think really the message here is we need more research, not only looking at, 5 to 60 seconds of time intervals, but what about longer or more implications about everyday life types of time tasks, because those don't last usually just 60 seconds.
Right, so there's no normative data. It sort of looks like these are just sort of mean differences for now, and I guess that would be future work. So yeah. There's another question. So this is a study based on existing data analysis, or did you work with living cases in senior homes versus right. So
as of right now, this is a scoping review. So it's looking at existing research that other authors or researchers have published. I've worked with individuals with dementia in my research, but not specifically related to this question about time perceptions. And right now, it's hard to know. I'm just going to answer the next question. I see it, Frank, if that's okay.
Yeah,
there's not really anything out there about time perceptions and interventions to help. And so that's sort of, it's a kind of a newer area of research. This is usually also done in quiet environments, lab-based studies, experiments. So they are, they're not taking into account the everyday kind of life. But I was very focused on this quantitative studies just right now to establish what was already out there so that we can maybe move forward and go into this other area of research.
All right. It looks like we're going to move on to the next person. Thank you so much, Natasha. And right. So our second speaker is going to be Barbara Delacourt. And she is a PhD candidate in speech-language pathology at the Université de Montréal, which is where I studied medicine. So we have a connection. She's interested in maintaining communication between people living with dementia and their caregivers in order to lessen their social isolation and reduce caregiver burden. And with her team, Barbara is developing a non-pharmacological therapy by using video to promote positive emotions. And to better understand how to facilitate communication between people living with dementia and their caregivers, her team is collecting multimodal data. So for instance, psychophysiological, verbal, and gestural responses that will be analyzed both via human expertise, but also via artificial intelligence. Bienvenue, Barbara. Please begin with your presentation.
Thank you. Today it's the first time I'm doing a presentation in English. So I will present the results of our implementation project in long-term care facilities with COMPAS. COMPAS is an evidence-based app available on digital tablets to facilitate people living with dementia participation. It is designed to support person-centered communication between a person living with dementia and the caregivers. So, in people living with dementia, communication difficulties are apparent from the beginning of the disease. These difficulties will create communication breakdowns that lead to a vicious cycle in which communication difficulties create a sense of frustration for each of the interlocutors. Exchanges, therefore, become more difficult and less frequent, so that people living with dementia find themselves isolated, which contributes to the aggravation of communication difficulties. As a result, caregivers may experience stress, anxiety, and a sense of burden that can lead to burnout. For their part, people living with dementia suffer from depersonalization in their care. So the rationale for COMPAS is based on evidence from non-pharmacological therapy that have demonstrated relevance, such as music therapy, snoozelen, and reminiscence. COMPAS lies in the concept of person-centered communication approach and emotional communication. It's an app on which personalized photo, music, and videos are added. All this content contains positive and meaningful memories for the person. The aim is that the emotions felt when viewing the content should serve as a trigger for communication. Our objective was to implement COMPAS in 2 long-term care facilities, one of which was Paul Bruyere in Montreal, and the other one was Saint-Victor in Amiens in France. This study is a pre- and post-experimental design. Our population consisted of 18 caregivers and 17 residents who having communication disorders and a diagnosis of dementia. We hypothesize that intervention with COMPAS will first improve the quality of communication within the dyad, improve the quality of life of the resident and the caregivers, and reduce the burden on caregiver. We used a pre- and post-test measure through the use of questionnaires measuring individual quality of life and communication. Semi-structured interviews and focus groups were conducted with the caregivers in the post-test. First, caregivers were trained in communication strategy in the use of COMPAS. Then, caregivers use COMPAS daily for 8 weeks with the resident. We conducted a content analysis. The verbatim reports were analyzed by 2 people in order to obtain an anti-judge validity. Then, for the quantitative analysis, non-parametric tests were used to study the differences between pre- and post-test questionnaires. Now, let's talk about results and discussions. First, about communication. The statistical analysis on the questionnaire did not show significant improvement. It was found that it lacked of specificity. However, the interviews highlighted the usefulness of COMPAS to elicit positive emotion in residents and the caregivers. This uprise in positive emotions lead to an increase in feeling of joy, pleasure, and happiness. Regarding residents, caregivers reported on the capacity of COMPAS to elicit positive emotions in residents as expressed by changes in their facial expression, like smiles, eye contact, expressing well-being and the pleasure they got from their COMPAS session, both verbally and non-verbally. Almost all caregivers discussed the positive effects on personalized content that photos or music from the resident's past can evoke positive memories and positive emotion. COMPAS is therefore a relevant tool to foster communication. The results are similar to VAS, who found that communication improved when the caregivers were trained in communication strategies and integrates the life history of the resident into the care. Next, about the quality of life of caregivers. We obtained a statistically significant improvement between pre- and post-test for the general S questionnaire. And also, we obtained a statistically significant results for professional accomplishment for the mass/burnout inventory. In addition, the thematic analysis supports the results that caregivers report that using COMPAS brought them joy, pleasure, and overall positive effect to their day-to-day. They discussed how COMPAS enables the development of more personalized relationships with residents. We also observed a decrease of caregiver burden, and the analysis highlighted how COMPAS gave caregivers a solution in their everyday struggles, providing them with a sense of empowerment and resulted in better bond with residents. These results are similar to the study by Claire and Edvardsen, which shows that relaxed and personalized care is essential for a good quality of life for everyone. And finally, about the quality of life of residents, the questionnaire did not produce statistically significant results. It was not adapted to the specificities of life in a long-term care. However, the thematic analysis shows that for the majority of caregivers, COMPA has a positive effect on the resident. Indeed, they note that COMPA favors the expression of positive emotion, the recalling of good moments, and the sharing of quality moments too. And this improvement is related to all the results we just have described. Finally, these results are similar to of Marta Zavide and Romy Chlidzent, as they report that meaningful communication between the resident and the caregiver is associated with a better quality of life. So the COMPAS study is continuing on a large scale in other CHSLD in Quebec, and we have improved our protocol by choosing more specific questionnaire to evaluate the communication and the quality of life. As a conclusion, COMPA is, as its name suggests, a compass that guides communication around the life trajectory of each person. It allows for the maintenance of exchanges by orienting them on emotion, which contributes to the quality of life of all. And above all, it appears to be a way of breaking the social isolation of the elderly. So thank you for your attention.
Merci beaucoup, Barbara. That was very brave of you to do that and this your first presentation in English. So we really appreciate what you were going through.
Thank you.
Thank you for sharing with us. And I'm going to look in the Q&A. We have a link. Right. So the question from Mark is, where is this app actively being used right now? Is it in long-term care or is it for people in their private homes? When might it become available, and what would be the costs for family caregivers? So there's a couple of questions in there.
Yeah, so the application is available also for long-term care and also for people who are living at home. And finally, we did study for both, also in long-term care and also for people who live in their home. And the app is around $13. And it's available only on App Store. You just have to write COMPA, or you can go on the website of my laboratory. It's Laboratoire en Saldo. And I guess I say everything.
Okay, that's great. So it's available to purchase now. So that's it's encouraging. And can you just tell us a little bit maybe of your personal experience? I'm assuming that you have sat and either with a person with dementia or watched a dyad using it. Like, just tell us a little bit about what that looks like, what it sounds like in real life.
Yeah. Finally, using COMPA, it's like a support to trigger communication. And when we use it, and when people living with dementia saw their memories who have positive effect on them, we see a lot of differences in their nonverbal communication, just like in their eyes, they are more present. And yes, there is a lot of changes in their nonverbal communication, and I can observe that, but also caregivers say they can see like in the difference in their eyes. So
So the person's reacting to it. So when you download the app, to personalize it for the person living with dementia, do you have, like, is it a lot of work to prepare it? Like, do you insert pictures from family albums or whatever, like into the app, or how does it work for setup? Is it how much work is it?
Yes, there is a section by person, and we can add photo, music, and video by ourselves, but family also can add a photo, music, and video whenever they want, and people can see that in the CHSLD. And we also have automatic suggestion for music and video when we enter the date of birth of the person, or also the date of arriving in Quebec if it's a person who comes from another country. And it's a way to add content very, very quickly, because we try to adapt it. The application for it. It takes the less time as possible for caregivers. And also we add a like mention. And when a caregivers try a music or a photo who was very, very good for the person, she can just put like on the button, and all other caregivers know that this photo, this music is very significant for the person.
Okay, so there's some crowd voting, and that happens where the different users can sort of like upvote questions with like in today's chat. But yeah, okay, so good. Okay, great. And so Mark added that he wished he would have had it so he could have used it with his own mom. So they're positive feedback there. Okay, if there are no other questions coming in the chat, then I think we'll move on. Thanks again, Barbara. And
Thank you.
We will go on to Guillaume Spalat. Guillaume is a PhD student in computer science at the Domus Laboratory of the University of Sherbrooke and the Centre de Recherche de l'Institut Universitaire de Gériatrie de Montréal. After being in industry for 10 years, where he became passionate about human-computer interactions and user experience, applied to healthcare. In 2018, he decided to go back to school and start his PhD. So the goal of Guillaume's research is to design assistive technologies for cognition for older adults with mild neurocognitive disorder. Bienvenue, Guillaume. Please begin your presentation.
Okay. Thank you, Frank, for the introduction. Okay, so today I'm going to present the MATCH project, which is an assistive technology for cognition designed to support independence at home for older adults with mild neurocognitive disorders. I will first present the background of MATCH, then the main features, as well as a demonstration, and finally give a short conclusion. So to live independently at home and in the community, we must be able to perform a number of complex activities called instrumental activities of daily living. For example, this can be cooking, managing medication, or using transportation. Older adults with mild neurocognitive disorders may require assistance with some of their instrumental activities of daily living. Many assistive technologies for cognition are available today to help them perform some of their activities, but their adoption rate remains low. To improve the acceptance rate of assistive technologies for cognition, the principles of zero-effort technologies have been developed. We decided to follow these principles to develop a new assistive technology for cognition. Our first question was to find a technology that theoretically follows the principles of zero-effort technologies. And we found that mixed reality using head-mounted displays could be useful in this context. Mixed reality is an emerging technology that aims to blend virtual elements into your real environment, which means you still see your real environment, but through the head-mounted display, you will be able to see virtual elements as well. So let me give you an example. Here, I'm walking around an apartment and there are no virtual elements. This is my real environment. Now, I'm going to make the same tour in the apartment in the right video, but with the head-mounted display, mixed reality display, so I can display virtual elements integrated in this environment, like here a list of the activities I have to perform today, or a message floating above the table encouraging me to perform an activity. I can also interact with those virtual elements, like here by touching a button. So it now displays a new virtual element, guiding me to another location. All those elements are displayed thanks to this head-mounted display. So you may think that this headset is big and heavy and that it will be difficult for the user to wear it all day. It can also be stigmatizing. And so you are absolutely right. It's too early to democratize it. And my goal is to see if mixed reality can have a use in this context. I do not want to study the medium used to generate mixed reality. We also expect that these headsets will become lighter in the coming years. To develop and design Match, we followed one of the principles of zero-effort technologies, which advise to use a user-centered approach. We first identified users' needs by means of observations, focus groups, and literature review. We then thought about potential assistances and scenarios by designing personas and conducting a co-design session. Then we developed and evaluate Match during 7 iterations with experts, followed by an evaluation with healthy participants. So let me now introduce the main functionalities of Match. At the heart of the system is what we call scenarios. A scenario describes an activity that we want to support. And to do this, we break the activity down into small actions that the person must do to progress through the activity, as in this example for watering the plants. Then, to each action that the person needs to do, we can attach an assistance that displays if the person is having difficulty doing the action or is not doing it. It should also be noted that each person may behave differently. So one person may need to go through all the assistance steps, but another one may perform the task without any assistance. To handle that, Match is somehow context sensitive. In this way, we can provide the person with sufficient and necessary assistance, which is suggested by our preliminary results. Another feature of the assistance is that they can be provided following a graded approach. So I understand that providing assistance first in an implicit way before moving to something more explicit is important to support the residual cognitive potential of people with cognitive impairment. We also add a second gradation related to mixed reality to make the assistance more visible if the person is not paying attention to it. Each assistance delivered by the system can be delivered following a graded approach. I'm now going to show a demonstration regarding an activity encouraging the user to dust his table with a rag. Here you can see an exclamation mark floating above the table, encouraging the person to dust it. If the person does not pay attention to it, then it turns yellow and then red. This is an illustration of the visual gradation. If Match sees that the person is paying attention to the assistance but is not taking action, then the person can ask for help if they don't understand what to do. The help does not appear immediately because we want the person to think for themselves first. So we make sure that the help appears only after some time. If the person asks for help, we enter the gradation from implicit to explicit. And if the person does not understand the message, like here, there is an activity to do, they may ask for more help, as you are going to see now, until we show the person where to find the rag, here with an arch. Then, if the person grabs the rag, you see that the assistance disappears because the system understands that there is no longer a need to display that assistance, and we can continue the task. This is also an example of what context awareness can do. And this is also what we mean by providing sufficient and necessary assistance. Match provide assistance to the user only if they cannot continue to progress in the realization of their activity without external help. Then the surface turns blue to encourage the person to clean the table. But if the person does not start to clean the table, then a message appears to encourage them to continue the activity. And as you can see now, when the person cleans a part of the table, it turns green. This is another example of context awareness. I also want to show you another example of how the system can adapt to the person's behavior. So let's go back to the first message you saw, indicating that there is an activity to do here. But instead of asking for more help, the person will say, yes, I know that there is an activity to do here. So the system stops providing assistances because the person seems to know what to do. But as you can see, there are no more assistances displayed. But you can notice that the person is not taking any action. So the system detects this and goes into action by displaying an exclamation mark above the rag to try to get the person's attention. And when the person grabs the rag, we resume the activity by showing the surface to be clean. So this is just an example of a scenario. This is all customizable. For example, we are developing a scenario for watering the plants, here on the video on the left, and another for storing an object in a cupboard, for example, in the right video. To conclude, I have presented Match, designed to support in theory any type of activity. We can easily add new types of assistance to the system. Match is also able to deliver graded assistance to encourage the person to act by themselves. Furthermore, our preliminary results suggest that Match is able to adapt to the context and to various users' behaviors by providing necessary and sufficient assistance. And finally, on a short-term perspective, we are preparing evaluations with older adults with neurocognitive disorders. In fact, the user study we conducted recently with healthy participants suggests that Match is now mature enough to perform such an evaluation. That's it for my presentation. Thank you for your attention.
Thank you, Guillaume. That's very interesting research coming from the Domus lab, as always. So before we sort of go into the questions, I wanted to ask you just from an EPIC and from a life journey point of view, can you tell us a little bit more about, your experience in industry and how you came to decide that this is how you wanted to transition into this domain?
Oh, yeah, sure. So in fact, my background is about computer science, but applied to healthcare. So I've always been interested in seeing how to apply those systems, informatics systems to, let's say, issues people can have in their job, for example. And in the industry, I've been working for, so to try to apply this to healthcare professionals, such as surgeons, for example, or pathologists who had issues using some systems. But then I was more and more interested in seeing, okay, how maybe we can also apply this to the general population and to, let's say, people who have also such issues at home, for example. And that's how I came to this willing to deepen this, let's say, this domain in going more into details about human-computer interactions applied to such domain.
That's great. It's always nice to hear people's stories on how they came to do the work they're in. Okay, we'll go to the questions. So the first question is about, sort of the cognitive load to use this kind of mixed reality. And for when we start thinking about people with cognitive impairment, how do you think they're going to be able to manage a system like this?
That's a very interesting question. In fact, we thought about cognitive load from the beginning, and that's also one of the reasons why we selected mixed reality as a potential technology. Because from the definition of mixed reality, you remove, let's say, between you and the assistants, you remove a medium, which can be, for example, the screen of your smartphone or your computer, because the virtual elements are integrated in your environment. So then you don't need to switch between the activity you're doing and the medium that provides you the assistance. And from that theoretical point of view, we believe that the cognitive load might be lower with this with mixed reality, but that's still an hypothesis, and that's something that we definitely want to check during our evaluation. But that's also why we designed it this way. So using the gradation, making sure that we have only one assistant at a time, that assistances are easy to interact with, for example. All those reasons, all those design choices are made to try to reduce the cognitive load. So that's thanks.
No, that's a great explanation, and I'd never thought of that. Sort of having to shift from the text on my iPad to what's happening in the kitchen is actually set shifting, and is actually might be more work than, like you say, just this overlay. So a very interesting idea. We have another question, and it's more about, does the system provide positive feedback once an activity has been completed? So you show it on the table, like the green boxes as they were evolving, as they were cleaning. But is there something like, the examples, well done, or thank you for cleaning the table, something like that?
That's also a very interesting question. Indeed, at the end of the activity, we have, let's say, a congratulation message. But for now, and yeah, you might have noticed it in the assistances that are displayed, they are pretty pragmatic, let's say. So there's not a lot of emotion or things like that, because for now, we are still in the development of making sure that the system runs correctly and that there is no issues. But indeed, we are thinking about trying to have something more pleasant to use. This might also take, let's say, the form of trying to gamify a little bit the assistance. But for now, our focus is to see if mixed reality can be useful in this context. So we want to first study this, and if this is positive, then of course this is in the pipeline, something that I would be interested to work on in the future.
Another question: what were some common barriers for the population that you studied to use this this assistive system, and how does the program address these obstacles? So like, what were the biggest challenges with older adults in the testing you've had so far?
Okay, so so far, as I mentioned, we didn't test it with people having neurocognitive disorders. So that's our next phase. So far, the way we have done the evaluation, let's say the development of match is with expert reviews. So, for example, with clinician people who tested the system regularly, and things that let's say came up from their comments, for example, was the importance of having simple interactions with the person. Another example was also to make sure that the person can escape, sort of saying, the assistance, because the assistance can be displayed at any time, anywhere in the environment. And if we want the person to use it as long as possible during the day, they should feel in control, for example. So to still feel that, okay, if I don't want this assistance now, I can just say, no, I don't want to see it, and then it will shut down. So things like this, for example. Also attracting the person's attention. This is also a challenge, because the virtual elements can be displayed anywhere in the environment, so it's easy to miss them. So how do you attract the person's attention to a virtual element without being too intrusive in the person's life? So these are, for example, things that guided us, but this is all to confirm in the study that we will conduct soon with the population.
Yeah, I'm just going to throw in one last question, and that is, you know, in my experience with people with more advanced cognitive challenges, getting anyone to wear anything is like a real challenge. Like even just a wristwatch, even though it says the time, like they're always picking at it, trying to take it off. Obviously, we're dealing with a earlier on stage, you know, of cognitive impairment. But what do you think the challenges are going to be, like to wear the device and to continue to wear the device, you know, for at least the duration of the task? Like, and how are you going to sort of manage that part of the user interface, which is like, it's bugging my head?
So indeed, with the current hardware, it's a challenge in itself, because it's heavy, and there are also other hardware issues. But because the technology is still new, the way we think we will do it during the study is to keep it short. That's, let's say, I think the only way which we can do it. So making sure that yeah, the study lasts for 30 minutes, 45 minutes, and that's it. But definitely to democratize it, if one day we want to have such technology being used, being democratized, we have this hardware challenge first to deal with. So manufacturers, big companies, have to design headsets that are as light as the glasses that we can wear. Otherwise, people won't use it. I'm pretty sure of that.
Great. Thank you very much, Guillaume. And so now it's my pleasure to reintroduce Genevieve Zaletny, who is going to be our commentator on the presentations today. Genevieve has a 30+ year career with the City of Toronto, where she led a data analytics team and worked in communications and learning. She served as a business leader, project manager, and change management lead. Currently, she designs, develops, and delivers data analytics courses. She served as chair, Houses of Providence Family Council, and serves as a caregiver partner Canadian Long-Term Care Connects Advisory Council. In addition, Genevieve has coached and managed sports teams, and she's a certified spin cycling instructor. Wow, this is exhausting, just saying all this, and was a member of Toastmasters for 10 years, where she won division level competitions and taught public speaking. So wonderful to have you with us, Genevieve. Please share your thoughts on today's presentations.
Thanks very much, Frank. Good afternoon, everyone. I'd like to share a few brief thoughts on the three presentations and then share a little of my own experience of someone helping to care for my dad with dementia. From Natasha's presentation on time perception, it was interesting to hear that people with dementia seem to underestimate time intervals. I certainly noticed this with my dad from a larger scale. Prior to having dementia, awareness of dates and times were very important to him. As dementia set in, he started to lose track of time, and this got progressively worse, where he was unaware of his age or even the day of the week, month, or year. Regardless, knowing that time was very important to Dad, we kept a calendar in his room and we would go through it every visit, striking off days that passed and highlighting important dates to come. Next, Barbara's presentation on COMPA. It was great to hear that COMPA is already available and accessible to families now. That was going to be a question I had. My father's communication as dementia set in deteriorated from a few questions and requests to only a few basic responses to questions, and then eventually no communication, which was pretty difficult. This affected different caregivers differently. For a caregiver like me, who's quite social and converses easily, I found ways to consistently engage and communicate with my dad. However, most other members of the family had very little conversation, which likely made their visits more challenging and shorter. COMPA would have made a great difference for them. And over to Guillaume's presentation on MATCH. Eventually bringing mixed reality assistive devices to people with dementia sounds really exciting. A place where I might see this happen was with my dad during meal times, where people with dementia often have to be reminded to chew their food and swallow their liquids. Perhaps it could help there. Finally, to share a little of my own experience helping someone with dementia, my dad. My dad passed away in September. He had dementia for about 5 years, which got worse over time. It was hard watching him lose his memory, his ability to use his legs and hands, and slowly stop communicating altogether. After about 2 years with dementia, we placed Dad in long-term care, which was really hard to do, as I imagine for all families. Here's 2 things that made my time spent with Dad great, even when he barely spoke or moved. First, every minute spent with Dad, I would work towards exuding as much positive energy and enthusiasm as I could to let Dad know how great it was to be in his company. Because I knew that he spent a lot of time on his own, not really talking to anyone, given all the complexities of his dementia. A number of visitors couldn't hide their shock of Dad's state, so this was pretty important. Secondly, and lastly, each visit I had with Dad involved a routine. I see COMPA coming here, specifically created based on things I knew he enjoyed. The routine included things like eating his favorite foods. He was a musician, so we would sing his favorite songs and even play them on the piano. We would visit friends and staff on his floor. And most importantly, we would go through 8 pages of his prized memories that I put together. He actually thanked me for going over them each time in his early stages of dementia. I know hanging on to these memories meant a lot to him. Again, COMPA is huge here. From what I saw, I do believe our routine brought pleasure to my dad, as well as to a number of residents and staff in the long-term care facility, and certainly to me. Invest time into making each minute spent with people with dementia special, as you would hope if the tables were ever turned. I wish everyone involved in this conference great success and wish to thank you for all your work to help those in need live better lives. Please continue to make these positive, important differences in the world. Thanks.
Thank you so much, Genevieve, for those personal notes. And then at the end of the day, it's exactly for people like you and for the people suffering with cognitive loss that we're doing this work. So thank you for personalizing it this way for us. So at this time, there's an opportunity to ask questions to the group, to individuals, follow-up questions. Certainly the presenters are welcome to ask questions to other presenters. This is meant to be a sort of a round robin, and we still have some time for it. So all right. So maybe what we can ask is, Allison suggested this, maybe I can ask each of you individually to just tell us what are your hopes for the future of age tech in your field first, but then in general. So, what are your hopes for the future of age tech in your field and then in general? So maybe we'll start with you, Natasha.
Sure. I love that question. And I think for me, I'm always coming to these kind of age well or age tech conferences from that social sciences perspective, which I think we don't always integrate as well as we could. And I think that more human side, the more looking at psychosocial factors, I think is really important. So I think in the future in general, I would like to see more psychologists, sociologists, et cetera, involved in this type of research so that we can think about those bigger issues, the ethics behind age tech, different things like that. In my field specifically, we're not very involved typically in clinical psychology in the age tech side of things, other than maybe online therapy. So maybe more clinical psychologists becoming interested in these applications, or even psychologists, would be of probably great benefit. So yeah, I'm hoping that we can just integrate more of that kind of more sciencey computer science side with the social science side as we move forward.
Great, thank you, Natasha. Barbara, your thoughts for the future of age tech in your field?
In my field, I have the hope that technology can help people to have a better quality of life. And I hope that people are going to be very creative to find a very accessible way and technologies that are easy to use for help people in their daily. And I'm very interested by the depersonalization in care. And I think that project, like, for example, COMPA, could be very useful to help professional caregivers to better know the person they help. And it's one of my hope is to help people to live in their home and in other care setting, and to have good care and personalized care, and that we preserve their personhood. It was not easy to say that.
No, we understood perfectly. That's great. Very, very, very thoughtful answer indeed. Guillaume, anything to add on your hopes for the future of age tech in the smart home?
Yes, so already Natasha and Barbara said a lot, and I fully agree on that, especially also from my interest in human-computer interactions and making sure that we design the technology for the human. So I hope that we already see a trend that more and more technologies are designed this way, but I hope that this will continue, because I think this will be very important. Ideally, seeing technologies that disappear, so that people in fact don't really interact with the technology, that the technology is able to do everything by itself, and that the people don't feel like they interact with technologies. So going more into that direction as well. Something else that I think is important is also finding how to democratize the technology. But here it's not only about designing it, but it's also how to make it affordable, how to make people aware of the technologies, how to make sure that we respect privacy, and also how do we involve maybe healthcare professionals to integrate these technologies with the end users without making this technology too difficult to maintain. So in fact, not adding extra burden, because we see a lot of new technologies coming, and that's something that I'm asking myself.
Thank you, Guillaume. Genevieve, did you want to add something about your sort of dreams of technology in this space in the future?
I did. I want to share a live experience once again. My mom, who's 86, we're not sure if it's Alzheimer's or dementia, but something's creeping in, using a bank machine. Okay, so one of the big banks in Canada is trying to push people away from person-to-person service, and they want them to use the bank machine. And she's almost chastised each time she asks a person to assist her, use the machine. And so I've been trying to teach her, and the machine doesn't allow for an elderly person to read the options in enough time to read and understand what they say. So by the time she reads the third option, it times out and she's got to start again, the whole process. And then a week or a month later, when we go to use the same technology to do the same thing, we start from scratch. She doesn't remember any of it from the previous time. So those that are designing and developing technologies that the people themselves, the people with dementia may use, please keep those things in mind.
Well, that's an excellent point. So I think that's actually something I'm going to throw out there again, which I think is one of the big challenges, right? Is there's sort of different pieces, like the idea of technology being an aid, a facilitator is very attractive, right? I mean, you know, I don't have to do math. I have a calculator that can do it for me, right? So it makes me more efficient. It's very attractive. But there's a lot of challenges with technology as well, and Barbara mentioned that a little bit. That sort of depersonalization, right? And we talk a lot about this. To a couple sitting at the table at a restaurant with the candle lit at the middle of the table, and both of them are on their phones, right? Is this, what kind of a date is this? Is this improving socialization, or is it depersonalizing the whole experience of a date, right? And so that, how do we keep the technology being a facilitator without depersonalizing, right? Without it becoming just a machine and do this. How do we keep it from getting too complex, which is sort of what Guillaume was talking about, right? Because the more tricky things we want it to do, the harder it gets to figure out how to do that, right? So I think that certainly is one of the big challenges we face with the technology. Does anyone else have any other reflections on that? Because I think it's really an important discussion.
I think it is really important to think about, instead of just let's design all the technologies, think about, do we need this technology and how to best design it for those who will be using it. I know there's implementation science methodologies which can help us understand what are the actual needs. And there's also a movement for de-implementization, when you kind of get rid of something that might not be working for an organization or for someone. So I think we need to take into account, if this is what is needed, or if there's another approach that needs to be taken.
Anyone else want to contribute to that? In the chat, right? The whole purpose of the technology is to improve the autonomy and the quality of life of people living with cognitive impairment, and to increase the workload of the caregivers. And I can completely agree with that, of course. And yet, with the current state of technology, I know that in my clinic, I try to suggest technology that could be added, but the caregivers are already so run off their feet and so exhausted from the caregiving that they typically have a job as well, and then they have children as well, and then they're taking care of their parents as well. And then we say, well, here's this cool technology that you could buy at Best Buy, but they're going, when am I supposed to do that? And how am I supposed to figure out which one of the 20 things on the shelf at Best Buy is the one that's going to help me the most? And then when I bring it home, how am I going to figure out how to set it up? And how am I going to involve the person living with dementia? And then how do I teach them to go back to Genevieve's point, right? I teach them how to use it, but then the next day they've forgotten because they wake up and they go, what's this thing standing in my kitchen or whatever? So the challenges with technology and especially cognitive impairment are certainly real. Okay, so I guess we can wrap it up and give everyone 10 minutes back. So I want to thank again our speakers, Natasha, Barbara, Guillaume, as well as Genevieve, for putting it all back into perspective and reflecting on those ideas. Thank you all for your effort, and thank you for the questions that came in from on the chat. And we are reminding everyone that, there's more EPIC talks to come over the next few days. And Allison, is there anything else I need to say, or can we call it a day?
Oh, we did want to advertise the PEP program. If you look at the bottom of your...
Yes, okay, PEP Talks, great. So Pep Talks is an e-learning series for researchers to enhance their knowledge translation skills for policy audiences. And so throughout this 4-part webinar series, researchers will learn more about how public policy development occurs and where research can inform policies, how to effectively articulate research findings, and how to prepare a policy brief on research findings. Excuse me. So this is really important, because this is where knowledge translation really matters when we're trying to get government to make changes to policy to adapt to the technology that we want to use. So participants will develop their own policy brief geared towards government on their research topic of choice to apply the lessons from the series in this final assignment. And so stay tuned for the registration regarding our first Pep Talk webinar beginning June 22nd. So mark your calendars. And of course, you can visit the AgeWell NIH APTA.ca website for more information about that. And right, and of course, you can always, if you have any general questions about AgeWell or the EPIC program or anything that AgeWell has put on, you can always email info@agewell-nce.ca for more information. Thank you, everyone, and have a good rest of your afternoon.